such a good question. I think the frontline space is just, it's almost like a soap opera right now. There's so many trials and so many different strategies being evaluated. Maybe I'll outline just a few of them for you. The first is, of course, can we bring some of these targeted therapies into the front line and combine them with immunotherapy? That is one of the standards of care right now. And so there are a number of strategies or a number of trials trying to do this. In particular, the one that comes to mind are KRAS G12C inhibitors plus immunotherapy. And boy, it would be great if we could treat patients in the front line with targeted therapy and immune therapy and not have to give them chemotherapy. So that's an area that I'm watching with a lot of enthusiasm. Another area is whether these antibody drug conjugates that we'll talk about a little bit more today can leapfrog from the second line space where they're likely to be approved first into the first line space in combination with immunotherapy. Once again, maybe also in combination with platinum. There are a number of trials, a number of sponsors that are trying to do this as well. And this would mean that some of the chemotherapy drugs that we've used for a long time, pemetrexed for non-squamous patients, paclitaxel for squamous patients, get relegated potentially into that second line space because these new antibody drug conjugates beat them out. And so that's also an area of interest for me. And then finally, these bispecifics. There are bispecifics that are threatening to take the place of the PD-1 and PD-L1 inhibitors that have been in the front line for about 5 years now. And so whether those drugs harness a little bit more of the patient's immune system so that they can generate more of an anti-tumor immune response is the question. Can those drugs be combined safely with chemotherapy as well? So there's some themes across all three of those strategies, but like, is more better? And so I guess we're just going to have to wait and see. You know, the truth is there are more trials than lung cancer patients to participate in them. And so that's a huge challenge. And it does seem as though some of these buckets of trials are evaluating the same question. Different KRAS G12C inhibitors with immunotherapy, for example. Different TROP2 ADCs in combination with platinum and IO as another example. And so, you know, I think a big unmet need is when are we going to start to work together a little bit more? Right now, investigators work together in cooperative group trials. At Sarah Cannon, we have a large physician-based network that spans 1 in 5 patients treated on cancer clinical trials across the country. So now we need some movement on the part of the pharmaceutical companies to work together to answer similar questions together in order to move forward so that we'll have enough patients to answer the trial question. There are still many, many patients who are not eligible for trials. And so there are still many, many patients that are receiving chemoimmune therapy and then maybe one other line of therapy. And the truth is that we're not curing patients with metastatic disease. One of the most significant unmet needs that pops out to me is that of patients developing brain metastasis. With drugs that may or may not cross the blood-brain barrier. That's probably an unmet need in terms of treatment, but also an unmet need in terms of clinical trials, because most clinical trials will exclude patients with brain metastasis that are untreated. And sometimes patients have not had their cancer brain mets treated for a variety of reasons. We need to begin to liberalize our inclusion and exclusion criteria in clinical trials to include more patients, to bring more patients to that group to answer the questions. And I think allowing patients with asymptomatic untreated brain metastasis might be one way to do that. So many great scientific abstracts reported at ESMO 2023. The two that jump out to me are the ALINA data, in which patients with resected non-small cell lung cancer with ALK rearrangements were randomized to receive ALK TKI alectinib versus chemotherapy, with an 80% reduction in risk of disease recurrence or death in the patients that were treated with the pill alectinib as compared to chemotherapy. And that also corresponded to the risk of CNS recurrence, which was also 80% reduced for patients that received TKI. This is a practice-changing study. It will lead to the identification of many more patients with a resected cancer that can be treated for goal of cure with alectinib, as opposed to being treated for goal of palliation or disease control in the metastatic setting. So huge win for patients. Another trial that sticks out to me was Keynote 671, also in the resected lung cancer space. So this, I wouldn't say was practice changing. I would say this is practice affirming, at least in the United States. Let me tell you why I say that. Checkmate 816, it was a previously approved trial in which patients got chemo and immune therapy prior to surgical resection. And it resulted in improved disease-free survival, event-free survival, as well as path CR rate and major pathologic response. And so that changed the standard of care. So most patients with stage 2 and stage 3 cancers will at least have consideration for chemoimmune therapy, carboplatin, another chemotherapy drug, and nivolumab in the case of Checkmate 816. Now, the PEARLS trial is an adjuvant trial that showed that after surgery, the addition of adjuvant pembrolizumab would improve survival as long as patients had 4 cycles of chemotherapy. So the way I explain Keynote 671 to the physicians in our network is just that it smooshed those 2 trials together. And in Keynote 671, patients got platinum chemotherapy plus immunotherapy upfront. They went to surgery, and then they got more immune therapy out back. And so I would say in the community, we've been doing this for a while based on the results of the 2 other trials I explained. And so the Keynote 671 affirms our ability to do that. So it seems to me that this will result in most patients getting immune therapy pre-op and post-op. This is a new area, right? Where TROP2 is ubiquitously expressed, in particular lung cancers, non-small cell lung cancer. It turns out small cell lung cancer may as well. We heard some results, some other exciting results, the Dato-DXd versus docetaxel second-line trial. Treatment in the second line for patients with non-small cell lung cancer improved PFS with a hazard ratio of 0.75. The surprising result of this trial was that the benefits seemed to be confined to the non-squamous patients. And in subgroup analysis, the squames actually didn't do that well. We also saw a smaller report of TROP2 ADCs in small cell lung cancer with sacituzumab govitecan. And it likewise showed response rates, I think, in the 30 to 50% range, 30 to 40% range, with duration of about 6 months. So it may not just be non-small cell lung cancer where TROP2 directed therapy is promising, but also small cell. I could go on for a long time from the abstracts from ESMO 2023. I might just mention one more, which was the HER3 antibody drug conjugate, patritumab deruxtecan. At World Lung, we reported the response rate for patients was around 30% for patients with EGFR mutated non-small cell lung cancer. And at ESMO, we reported that patients treated with patritumab have responses in the brain about 30% of the time. So the systemic disease control is recapitulated in the CNS. Said another way, if you're using patritumab deruxtecan for patients with EGFR mutated cancers after osimertinib, it'll work in the body as well as the brain. And so that's a great step forward. Antibody drug conjugates are big molecules. We weren't sure whether they crossed through the blood-brain barrier the way TKIs do, and this data would suggest that they do have activity in the CNS. And so one other therapy to give hope for our patients.